good to start telling us about Moira's journey as we move forward. Everyone will kind of come back shortly. So
sure, that sounds great. All right, so just to continue to the next part. So Moira, we're gonna explore Moira's life in her second half of her glorious experience. Just some quick notes that a lot of these slides are adapted from info and slides that I got from Addie and Megan and Rachel Young as well. So thanks for all of that. And I have no disclosures. Okay, so let's start with breast cancer screening. Some of you guys who may have been on Academic Half Day for Women's Health Day last year probably will recognize some of this information, but it's kind of a it's like a deceptively simple topic. I think it is a little more complex. So I think a little extra review, never a bad thing. Just to start with some objectives, let's identify the risk factors for breast cancer. We'll take appropriate breast cancer family history, integrate a stepwise approach into developing breast cancer screening plans, and then just get a sense of the risk calculators, and then we can assign people into the right risk category. So just some quick facts about breast cancer to get us started. So it's the most common cancer in women worldwide. 1 in 8 women in the US will develop breast cancer over their lifetime. It's the second leading cause of cancer mortality. And breast cancer screening is important because it's very actionable. It does reduce breast cancer mortality and morbidity. And it's also something that can help you adjust their screening timeline if they need genetic testing, if they have any opportunity for risk reducing surgery or medication. So it is an actionable screening to do. So just to quickly think through breast cancer risk factors, we will start with a question. So Moira Rose is now 42 years old. She presents to clinic for a wellness visit. You begin discussing breast cancer screening and you gather some of her history to determine her history. So which of the following are going to put her at an increased risk for breast cancer? A, C, and D. That's great. Okay, so A, C, and D, and let's just follow through some of these risks. So personal risks, if people know they have a known mutation from family, that's always an important risk. If they've had a prior biopsy that shows anything abnormal, prior cancers, breast density, we'll talk about that in a second. Age is one of the biggest factors, which is why we start thinking about it as patients get older. Family history, and we'll talk through how to do a family history, but really thinking through a lot of pieces about their family is important. And then hormonal issues. So when you are gathering this data, the reason it's useful to think through is that it will help you put all that information into some of our risk calculators. So getting a history on how many children have they delivered? Did they breastfeed them? Hormone therapies in the past, menarche, menopause, ages, and then what their weight is.
And there's a question.
Oh, yeah.
Is breast density itself a risk factor?
Ah, great. Thank you, Addie. We will get there in a second, too. So just to show a quick thing about age, the prevalence of breast cancer the incidence of breast cancer really just aggressively ticks up as age goes up, which is why we start to think about it for our patients as they are getting older. And then just a couple things to think through that have really high relative risk for personal breast cancer risk. Things like chest radiation, if a patient had a prior cancer history and treatment, if they've had any chest radiation, that is something that immediately is important to know. And then thinking through some family history again, the lowest density breast compared to highest density categories do have, the highest densities do have a higher relative risk. And then some hormonal pieces as well that we talked about. Yeah. Oh, that's a great question. I don't have that in my list of things that I think through as, okay, alcohol can increase levels of estrogen, other hormones associated with breast cancer. Yeah, so I think it's something to think about in that like hormonal picture for sure. So thank you for bringing that up. So breast density, just to put it out there, if you are talking with patients often enough about this, they will probably start to have questions because they will get this notification in their mammogram about their breast density. The information that we have right now is that dense breasts can make it harder to find cancers, and they also can increase their risk of cancer itself. So it is common, it is normal, it is not something that people need to panic about, but just being able to talk through with patients that it's just kind of more important to think through their screening if they do have dense breasts. Okay, so if we're thinking about breast cancer screening, we kind of want to think through a patient's risks and how to assign them into the right risk category. So the first thing we need to think about is the fact that there's average, intermediate, and high risk. The average lifetime risk for breast cancer for women kind of across the board is 12.4%. So if, and we'll work through how to sort people into these groups, but that's kind of the number that we're thinking about when we think about these average risk categories. And that's what most of our screening guidelines are based on, is for women in the average risk category. So step one, when you're talking to someone in clinic, you want to get a family history from them. And when we do that, it's really important to, I think, drawing a pedigree, I think you can, in truth, in practice, I don't draw pedigrees for every patient, but I sort of get from them, like, tell me specifically who had cancer, not just like, oh, a cousin or a grandmother, like which grandmother, on what side, how old were they? Did they have one cancer? Did they have two cancers? And I think if you start to elicit from them that if they say like, no, not a single person in my family had breast cancer, or there's only one person, like this practice is maybe not as useful. But if you start to get the sense that there's maybe a couple layers of things in their history, then I think it is really useful to draw this out, because it can help you determine information you're going to put into a risk calculator as well. Once you have all that information, if they do have, and this is the thing that, again, if people have pretty minimal cancer history in their family, I don't tend to whip this out, but this is this NCCN guideline. There's also a USPSTF tool for assessing when patients need to be sent to genetic counseling. But if you have a mix of patients, a mix of family members with cancer history, it can be useful to just pair that up with one of these and see if they kind of meet those recommendations to get genetic counseling. Okay, so you have a patient who has somewhat of an extensive family history. You look through the tool, you can decide, okay, yes or no, they should be seen for genetic counseling. If they don't have an intense family history, then you can just move on to assessing their personal risk. If they do and they go to genetic counseling, they will then at genetic counseling get determined into high risk group or not. So moving on to the personal risk group, and this is where we gather that information that I was talking about before. So parity history, hormone medication history, if they've had biopsies themselves, specifically thinking through, did they have any atypical ductal hyperplasia or LCIS in biopsy histories, that chest radiation piece I mentioned, and then do they already know that they have a high risk mutation? So any of those things automatically put them in a high risk group. But if not, then you can keep on moving down the model and go to step 3. So you say how you've gathered all their family history, you've gathered all their personal history, and now you really want to put them through a risk calculator to decide what their actual risk number is, so you can kind of sift them into a box. We will talk about maybe 2 briefly. There are 3 different tools. The NCI breast cancer risk assessment tool, I won't talk about too much, but the BCSC is a relatively easy tool to use. You can Google it and find an easy website to go through. I think this is great for patients who you have their breast density in your hand from a mammogram, or they don't have a ton of cancer history in their family. The next one is the TYRER-CUZICK model. And this one is a little bit more time intensive. So if you get a patient who is giving you a family history that's pretty extensive, this is really the best one to do, because it can input all of that data. It also will give you a lifetime risk instead of a 5 or 10-year risk, which I think BCSC does not do lifetime. But either way, the important thing to note is that you do have to put in every family member. So if they have 6 sisters, they all have to go in there. If their mom has 4, you know, if she has 4 aunts on one side, like you have to put them all in there because it sort of just affects the risk because it gets pooled for. So once you use those tools, you will get a 5, 10, or lifetime percent risk. And once you have those numbers, you'll be able to put them appropriately into these average, intermediate, or high risk groups. So while we're thinking through these groups, I think, you know, the average we'll get to in a little bit. Let's start with high risk because I think that's the one that is a little bit, it's more specific. Intermediate, as you'd expect, kind of falls in the middle. So we'll start with high risk. So as I said before, the average lifetime risk of breast cancer is 12.4%. So the people that fall into this high risk category are anybody who is over 20%. So 20% lifetime risk, or 5-year risk of 2.5%. But just kind of thinking about that comparison to 12.4, if you're over 20, you are in a high risk group. Other people who automatically get put in a high risk category are someone who knows that maybe they know they have a BRCA mutation from prior workup. They have a personal history of breast cancer, of course, if they have a high risk lesion, and then if they've had that chest radiation that we talked about before. So if you are in a high risk category, and that's something that's important to kind of determine while you're doing your screening counseling, then there are different guidelines for how we screen these patients. So a number of different groups have recommended that we do annual screening starting at age 30 if their risk is based solely on like their individual, their risk that you get from those calculators of over 20%. If you have a family member that was diagnosed young, then you should start to screen 10 years before the age that that family member was diagnosed, but not before 30. So in both cases, kind of thinking about 30 as our starting point, but maybe could be a little bit later if someone had a family member diagnosed at 45%. And also with chest radiation, a little bit different. So age 25 or 8 years after their radiation. And then in addition to the timing being different, the actual way that we screen them is different too. So we don't just do mammograms. The recommendation is for an MRI and a mammogram, both once a year, and typically they get staggered every 6 months. So it's pretty intensive screening and imaging for patients, which is why I think it's just important to have these conversations and really have like patients involved in the discussion, because you know, this is like if it's hard enough to get someone to go to a mammogram once a year, trying to do 2 different things every year is a lot. So, you know, making sure that they understand the plan and what's going on and why it's important. Okay, so we'll jump to average risk, which I think is the highest number of patients in our group. Oh, no. So not chest x-rays. Thanks for that question. So this is really if the high risk radiation exposure is really if you've had radiation therapy. So if you've had a CT scan or you've had an x-ray, those things don't apply. It's really only if you've had like directed chest radiation therapy. So someone with Hodgkin's lymphoma or someone who had like directed treatment at their chest cavity. Thanks for that question. Oh gosh, we'd have a lot of people in the high risk if it were just from imaging. Thankfully, it is not. So our biggest group of patients is really going to fall into this average risk group, and this is where we think about all of those guidelines, the many of them that come out from different groups. So the average risk people, just to kind of work through who is in that bucket, is anyone who has they don't have any gene mutations. They don't have cancer or high-risk breast lesions personally. They don't have first-degree relatives with breast cancer. Their lifetime risk is right in that average sweet spot. It's under 15%, and that's after you've done their risk calculator. So here is a list of all the different groups that provide guidelines around breast cancer screening for average risk patients. I think, you know, this is a really difficult thing to sift through because you could follow any of them and sort of be in the right. I think this is really where having this conversation with your patient about what their goals are, what their worries are, what would help them have peace of mind. I think all of this stuff comes into play to just highlight a couple, the ones that internal medicine tends to use or lean on is the ACP and the USPSTF guidelines. And in those, generally between 40 to 49, it tends to be individualized. So you can discuss it with your patient, they say, but they kind of recommend starting true screening around 50 is kind of the hard cutoff. And then they recommend every 1 to 2 years, and USPSTF actually says every 2 years once you're 50. And then in both those settings, stopping at 75. But again, you know, a little bit of leeway around like patient conversation. The reason for the every 2 year screening is that there were randomized control trials done, and they found that doing screening every 2 years versus 1 year did reduce breast cancer mortality. And it also, it kind of tipped the balance in what was felt to be an appropriate way to reduce breast cancer mortality, but reduce the risk of you know, false positives and having to do extra biopsies, so that every other year screening was felt to be appropriate. And that's for ACP and for USPSTF. One thing I really want to call to everyone's attention though, which is something that I think we don't think about and talk about enough. And this is really based on a lot of work that one of my research mentors, Rachel Young, does. She's a breast oncologist at SCCA. And I think it's really important. This whole talk, I think, could be summed up with you need to talk to your patient and have like a really patient-centered conversation. But I think it's really important to understand that Black women have a much higher mortality rate from breast cancer than white women. There are a myriad of reasons for this, which, you know, not dissimilar from other problems in the healthcare system. There's a lot of bias and access issues. But I think just to speak to some really specific things that have been proven in research, there is a higher stage of disease for Black women who are diagnosed with breast cancer. They also get diagnosed with more aggressive cancer profiles when they're diagnosed as well. They are diagnosed at earlier ages. There are found to be more delays in care. And this kind of goes across the board from delays in diagnosis, delays in starting treatment, delays in completing treatment. There's also a higher rate of non-standard therapy, and there's a lower rate of completing endocrine therapy after their sort of chemo or surgical treatment. And then there's also things like lifestyle risk factors. So things like high BMI, there's just a higher prevalence of some of these risk factors across, you know, obviously this is a very like generalized statement, but across the, like the Black population. So when I listened to some of the research and talks from Rachel Young, she really makes this like great case that it's actually really important to think about this idea that maybe screening at 50 is contributing to inequities across patients of color, specifically Black patients. I think just to say there, I don't know of data, and I don't know if there is data yet, as there maybe should be, about like other patients of color and maybe other groups of like how these numbers look across different races and ethnicities. But I think just to say, I think that for Black patients especially, but really for any of your patients that you want to think about talking to them, at least start the conversation at 40 and don't wait until 50, because there may, you know, I think by doing so, we may be exacerbating some of our inequities.
That's a question.
Yeah.
What's the reason why not?
Oh, that's a great question. I don't know. I can only imagine it is multifactorial, but I don't want to quote things that I don't know, but I know that has just been found to be a cause for some of the higher mortality. But that's a great question. I will try to find that out and get back to you guys. Okay, so next piece is when we are, so, you know, when we have these conversations with patients about any kind of cancer screening, but specifically breast cancer screening, I think, you know, we want to be armed with some of the tools to talk through, like how, you know, if patients are supposed to think about how to weigh their risks and benefits, we have to provide them with the information to think about. So I think the benefits of mammography or breast cancer screening are definitely that more cancers are detected, we are saving more lives, we reduce the morbidity and the treatment burden of cancers found at a later stage. I think the risks are not insignificant to many either. So mammograms are not comfortable, they are painful, they are really stress inducing. Anytime you have false positives, that of course creates a lot of anxiety and perhaps like additional testing that maybe wasn't necessary. You're also getting exposure to radiation, and there's a cost to them as well. So I think, there's no one perfect solution to cut across the board for everyone, but just being able to discuss these things with your patients and really just making sure that they know and understand kind of what their goals are. I think that's just really important to do. And then just a little shout out about breast exams. I think there's been a slight shift since I feel like the time I was maybe in medical school till now, where I think there used to be, and I think in the community, there tends to be this like common feeling where people need a breast exam every year. And I will often see patients in clinic in their 20s who come in and say like, I'm here for my annual breast exam. And I think in this setting, there's not a lot of, I think there have been some studies that show that there is not a ton of benefit to doing an annual exam when it is otherwise not warranted. I think I've heard other oncologists like in the breast oncology space say like they would recommend doing a breast exam annually for people starting around 40, which kind of fits with, if you're starting to think about cancer screening then maybe doing an annual exam is useful as well. I think the thing we used to say that women should do monthly breast exams, but the thing that we're encouraging now is breast awareness. So, people don't need to like stand in the shower and like aggressively do an exam every month, because they will probably ended up people are finding a lot of things that cause a lot of anxiety and not so much pathology. But I think being aware of things, and obviously when you talk to your patients about this screening, encouraging them to say like, if anything comes up, if you find anything, like please do come back, sort of like, getting back to that piece that Nina was talking about before, just like broaching the topic where maybe people wouldn't think about it or wouldn't think to come in. But if there's anything that concerns them and sort of talking them through what symptoms could be concerning, then encouraging them to come back or to come in for an exam. Okay, so just to summarize, I think for average risk, we want to think about talking about it at 40, between 40 and 50, maybe starting screening during that time. Encouraging people to start at least every other year or every year, depending on what their goals would be. All right, so then we get into this lovely gray area of their intermediate risk group, which really falls in the middle. And I think once again, doesn't have a ton of clear guidance, but we try to just like meld the two together from average and high. So who fits in intermediate? So that's going to be all of our patients who get those TYRER-CUZICK or BCSC scores of 15 to 20%. Or there's maybe just like something about their history that doesn't quite tip them into like having a genetic mutation that's been found, but there's just something that you kind of get this sense that maybe they don't quite fit in a perfectly average group. So once again, just emphasizing shared decision-making. I think there have been some groups that have said, start screening at age 40 if you think they're higher than average risk. You can then also consider that whereas average groups were starting at 50 and then doing every other year, you could think about starting at 40 or 45 and maybe doing annual instead of every other year screening for them. In general, for intermediate risk groups, there have not been studies that show MRI is clearly beneficial for these groups. I think if it's based on a family history, that if that's what tips them into this category, there's not a lot of evidence for or against it. So I think we tend to not. But if the intermediate risk is based on, like if you go through their score and the risk that tips them in is that they have very dense breasts, the societies do not report or support the routine use of MRI for additional screening. So only if they tip into that truly high risk category, that's when we start to use MRI instead of just mammogram. Okay, so let's see if we can apply.
Sorry, can I go back 1 second, which is just to add that you had ultrasound on there. That's what a lot of people were getting for a long time. So there are definitely people who come in and are like, well, don't I also need an ultrasound? Or they get their density letter and they go on the internet and they want to talk about that. So just emphasizing that point, that that's not recommended, even if you're at, have dense breasts or intermediate risk. Really the better part of valor is just to ensure that they do their mammogram yearly, probably as a better screening strategy for that person than every other.
Awesome. Thank you so much, Addie. I think one other thing I would say is there, getting familiar with the TYRER-CUZICK scoring system, I think will start to benefit people if, you know, especially if you're here for the next few years in residency, but if you're staying in the area, I think I've heard that they're going to start putting the TYRER-CUZICK scoring in mammograms and like the reports that patients get. And I think that that's a UW specific thing. I don't think it's like a state mandated thing the way that density was, but I think patients are going to start receiving this information. And so as clinicians trying to familiarize ourselves with how to talk through it and make sense of it for them, I think it's going to start to be really important. So I think if we think about all this average, intermediate, and high risk, let's try to apply it. So after talking with Moira, she would like to know what her breast cancer risk is. So her clinical history includes paternal grandmother with breast cancer diagnosed at age 72. She has heterogeneously dense breast. Her TYRER-CUZICK score is 13%. She has no known mutations, no personal cancer history. What box would you put Moira in? Bucket, I should say. Average, perfect. Yes, so I think there's some, maybe like a little under half the group voted for intermediate. I think that is a reasonable thought. I think once the family history and the dense breast, I think could make you wonder if she has a high risk, or sorry, an intermediate risk. And certainly this would be one of those situations where you would talk to somebody about it. And if they're really worried, maybe you think about starting earlier rather than at 50. But because you put all her information in and you got this lifetime risk of, I think it was 13%, she fits in this average risk category. And the family history of one person diagnosed at age 72, so that's postmenopausal breast cancer, that's thought of in a slightly different way than if someone were diagnosed at 42 versus 72. So yes, this person, Moira, at this point in her life is an average risk patient. Great. Okay, so before we take a little bit of a break, I tried to collapse a lot of this information onto one slide as sort of a summary slide. So once again, step one is really like sitting down with patients and getting that family history, using those tools from USPSTF or NCCN if you're starting to get a sense that they have a slightly more involved family history, and thinking if they need to go to genetic counseling. And then the next is getting their personal risk factors. So all of their hormonal history, their biopsy history, cancer histories, all of that. And then thinking about which model you'd like to choose, putting a little plug out there for getting familiar with TYRER-CUZICK, because I think we're going to start seeing it more and more with patients having questions. And then once you have all of that information, you can sift them into one of the average, intermediate, or high buckets. High risk, then in that group, we're really thinking about annual mammograms with annual MRIs every 6 months. And then for average risk patients, we are following, mostly people tend to follow in internal medicine, the USPSTF or ACP. So thinking about starting at 50 and every other year screening. But once again, really thinking about shared decision making and thinking about, especially for our Black patients and other patients that we are a little bit more worried about extra risk, perhaps starting around 40. And I think that is where, oh, perfect. Okay, cool. Yeah, we will take maybe a 5-minute break and then we'll come back and we'll get to the next chapter of Moira's life.
Like right
Okay, so we can start talking. I think the breast cancer screening one was our slightly longer piece for the second half of our morning. These next two we'll do menopause and osteoporosis. A little bit more of like an overview, just because I think these are things that people may or may not encounter a whole lot or think about a whole lot in their clinic, but just worth having some good background information. So for, let's see. There we go. So for menopause, our objectives will be understanding an average timeline for and menstrual changes for average women going through menopause, learning the symptoms and treatment options for that's a typo, but common symptoms and treatment options in menopause, and then discuss hormone therapy risks and benefits, and listing a couple causes for iatrogenic menopause as well. Okay, so a little bit of an intro. So let's just define the words we use when we talk about menopause. I think there's a lot of things that get tossed around, like menopause transition period, or like late reproductive years, perimenopause, postmenopause, menopause, premenopause. So like all these different words that get used. And I think just to say it clearly, menopause is the actual time. It's a funny thing to think about because you diagnose it retrospectively, like you can only say someone is in menopause after they've gone through 12 months of amenorrhea without other causes. So the time leading up to that is really when you're having all of this irregularity. So perimenopause is really between reproductive years and then formal menopause. So this is when you start to have irregular menstrual cycles. You'll start to see some of the hormone changes that cause some of these symptoms. And then menopause is like the definitive depletion of ovarian follicles. Estradiol production is stopped, and there's a permanent cessation of menstrual periods. During this period, FSH is elevated because there's no estrogen being created to oppose it. But a high FSH is not required for the diagnosis. So as we'll talk about a little bit, checking an FSH is not required to confirm someone is in menopause. Okay, so just thinking about average ages for timeline of menopause. So the menopausal transition, which is really the beginning of that perimenopause that I mentioned, generally starts around 47 years old. The median age of menopause completion itself is 51 or 51 to 52 years old. And I think if you are seeing a patient and they are discussing irregular menses, and they're starting to have menopausal symptoms, if they have those things and they are over 45 or older, then you can sort of confidently say that they are in a menopausal transition. If they're which is to say that they're perimenopause. If they're 40 to 45 and you hear these symptoms, you don't want to just assume it's menopause. You want to think through, like, could this be, think about like what their family history was. Did their mom have menopause at 42? Is there anything else going on that could be causing these changes? Because that age is a little bit on the early side. And then if this patient is any younger than 40, then you need to do a full workup for primary ovarian insufficiency, or think about like amenorrhea or AUB, kind of like Nina was talking about before. So before 40, don't let menopause just like be your differential of exclusion. Like you really got to work through some other things first. Okay. Just to think through some menstrual changes that start to happen. So in late reproductive years, and this is kind of like early 40s, mid 40s for different people, cycles will begin to shorten. Once you enter into that perimenopause phase, ovarian follicular depletion will start to happen over time. While in the beginning of this whole phase, the cycles were shortening. At this point, once you're in perimenopause, your bleeding patterns change, and you sometimes will just have like lengthened menstrual cycles where you're sometimes just skipping them. And at this point, you're more frequently in a state where your FSH is high because your estradiol is low. But you kind of, women tend to kind of jump in and out of these phases. And so just testing to see if they're in this phase, it's not really a guarantee either way. And then once you hit menopause, you've had those 12 months with no periods, you have no menstrual cycles, and the FSH increases over time to be, 50, 70 to 100. And then as people continue to age, past 60, they'll start to decline as they get older. And then this will get back to that question. I think, I can't remember who asked this question before, but about birth control and menopause. So women who are perimenopausal really important to think through the fact that they are still able to get pregnant. They are still ovulating. It is irregular, but just because they have not truly hit menopause, it is possible to get pregnant. It's unlikely, but it's not impossible. So just another situation where if people are starting to have perimenopausal symptoms, to just consider discussing with them like what their birth control is, if they would like to be on it. Another thing to think about with birth control is that women who are on birth control, if they're on a birth control pill, because their cycles are being iatrogenically managed, it's hard to know if their cycles are changing. So if people are starting to have symptoms, they may, or they're just curious, if you need to know if they're in menopause, you really need to stop the pill and then measure FSH 2 to 4 weeks later. So this is in one of those situations where stopping and then you can check FSH to get a better consensus. If it's over 25, they've likely entered a menopausal transition. I've read some guidelines that said at 50, you could confidently, it looked like OBGYNs were kind of confidently stopping birth control because their chance of conception is very low. I think that's reasonable. I, again, would just kind of recommend patient discussion if people are not really confident about that, or they have maybe their history, their mom or their grandmother or somebody always had menopause later in life, then totally appropriate to consider continuing that.
There's a question.
Yeah. Oh, I think that's a good, so the question about like what birth control method would be best during menopause. I don't think that there's any like hard guidelines about ones that are like contraindicated or ones that would be better rather than others. I think if people are already using one that works for them, I don't think there's a need to necessarily stop that. But I don't think there's like any one thing. If Megan or Addie have other thoughts, please jump in. Okay, cool. So menopause, oh yeah.
Sorry. I was just going to say, yeah, whatever they're on, if they're happy with it, fine. Otherwise, it's kind of like anything else. Like, what's the main goal that they want? Are they having irregular bleeding that's bothering them and they're open to like they're not having a lot of hot flashes? Maybe a Mirena is helpful to them. Like if they're having some symptoms or they want the estrogen for other like non-contraceptive benefits, then a low dose estrogen pill, like something in the 20 microgram range, is fine. And Megan, I don't know if you want to add anything.
Nothing else to add. I totally agree with all that.
And then there was another question. Do you have a framework for fertility discussion for someone who's 45 years old, premenopausal, and hoping to become pregnant soon?
I think in that setting, I think maybe there's a computer with sound on. I think in that setting, I would say that they should probably just see fertility clinic. I think once you're over, I think 35 is, I can't remember 30 or 35, but definitely over 35, if you're worried about pregnancy, I think just kind of skipping past the pieces of like menopause questions and birth control questions and just go right to fertility clinic because you're, working with a little bit less time. So it's a time sensitive thing. Okay, so just to think through some symptoms and then how we can treat them. Even as someone in the women's health pathway, I still feel like frustrated with menopause sometimes because I think it had been hard to know like how you can actually provide treatment. But in doing this talk, I got a chance to like read a little bit more about how we can offer some different things. So let's think through Moira's age. She's now 49. She returns to clinic to discuss hot flashes that she's having. Which of the following are considered proven therapy options for perimenopausal hot flashes? I don't know if we have a poll that will pop up. Oh, perfect. Sorry, this is a long list of options here. B, D, and E. Okay. All right. I'm getting the sense from this poll that people are saying either all of the above, or people think SSRIs, systemic hormone therapy, yoga, and CBT are working. So people are not jazzed about clinical hypnosis. And I was really interested to learn that clinical hypnosis is a proven therapy, and yoga and trigger avoidance have actually not been found to have a ton of efficacy behind them. So thinking about hot flashes, the other term that you'll sometimes see when you're reading about them are vasomotor symptoms. So VMS is sometimes how they're described in different guidelines and literature. So what are they? Just to say what they are in detail. So people sometimes get a flushing sensation, someone in their chest and face. It can spread around their whole body. Sometimes it results in sweating. They're obviously a little bit of a heterogeneous mix of symptoms, but they're common at night. They also can happen multiple times a day. They are very common across the board for women. 75% of women have been reported to have these symptoms, but unfortunately, very few of them seek care. They're also really frequent in perimenopause, but they can last up to a full decade. So these are not typically things that just go away on their own after a year. A lot of times people will have these issues for a lot of years of their life. And it's unfortunate because they're really associated with poor quality of life, sleep problems, mood problems. It can start to impact depression and anxiety. And so a lot of these things within menopause are a little bit like circular in that they kind of bleed into one another. So thinking through how to treat it is really important for people. So it is definitely useful to think through hormone therapy. And would this be something useful for your patient? Because it can reduce their symptoms up to 95%. So like an across the board, like, oh, I'm not comfortable with hormone therapy, you're really like limiting people's ability to find relief from these symptoms. But then some non-hormonal options, I think, which are appropriate to start with are, so there's not any good data for these, like for telling people to like fan themselves or avoid triggers, exercise, yoga, supplements, all things that, like, yes, I agree, in life are probably great for your health, but not specifically going to help your hot flashes. But things that have been shown in different studies to be useful are CBT. There was a clinical hypnosis study that I saw in this talk that they were talking about that had some good results. SSRIs, gabapentin, clonidine, and there's some data being, or research being done around oxybutynin, which is interesting to think about too. So the next common thing that people experience is this GSM, or genitourinary syndrome of menopause. It's, again, a little bit of a mixed bag of symptoms, but it is kind of all encompassed in this GSM word, or that you'll maybe see when you're reading about it. The symptoms include really things that are related to like vaginal dryness, pain with sex, irritation, itching, and also a lot of urinary symptoms. So frequency, urgency, incontinence, frequent UTIs. And the reason for all of this is that as your estrogen is dropping, the epithelium and the urethra are both estrogen dependent tissues. So those tissues start to thin and you can start to get vaginal atrophy. This happens in, at least half, if not more, like 3/4 of women going through menopause. It's also really common in breast cancer survivors. It's chronic, it's progressive. So unlike hot flashes, which eventually usually will tend to tip away after a couple, many years, this tends to continue to get worse. There are some treatment options. So there's recommendations for activity treatment. So having regular sexual activity, a lot of recommendations for like either with partner or with self, dilators, pelvic PT, just things that can help to stimulate that area and make sure that people are getting like more exposure, and it can help with comfort. There's some non-hormonal options, things like lubricants and moisturizers, which, and also topical lidocaine. There's some like emerging things about laser therapy, which I won't get into, but something that's like maybe on the horizon. The moisturizers are things that you would think about on, I always mix them up. I think moisturizers are things that can help people on a daily basis. So if they have symptoms all the time, but lubricants are something where if people are having just pain when they're having sex or just pain with certain activities, then you can think about the lubricants then. And then there are hormonal options too, which can be super helpful to treat. So vaginal estrogen, vaginal DHEA, which I think is still kind of getting some studies done, but then systemic estrogen as well. there are some more studies needed for a number of things, but there's also this thing that I was reading about last night, which was kind of exciting to think about how that can evolve, is ospemifene, which is a SERM. So it is a vaginal agonist of estrogen. And I think that's something that's, you know, maybe just keep your eyes open for things about that in the future. And then just to call out a specific patient population which struggles with a lot of these symptoms often are breast cancer patients, so breast cancer survivors. They have a lot of challenges with these because they often are having early menopausal symptoms because of their hormone therapy. The symptoms can be worse. They can be on, often they're on endocrine therapies like tamoxifen or AIs. And so there's appropriately a lot of fear about giving any of these patients anything with the word estrogen or progesterone in it. There's not a lot of data about like specific therapies in these populations. There's kind of like mixed reviews about a lot of different things. So definitely need some more work done in that space. And then I think the other thing is that we don't have a really firm consensus from what I've read about whether local estrogen causes a concerning increase in systemic levels of estrogen, which is really what you'd worry about for a breast cancer recurrence. So there's no need, like checking an estrogen level is not going to really be beneficial. We don't have any sense of like what number, kind of like your COVID antibody, like we don't really know what to do with the number, so don't check it. But first line, I think always recommend and work through like lubricants, moisturizers, topical lidocaine, make sure that you're kind of exhausting those options with any of these patients who you might see in clinic. And then second line, and this would be kind of with consultation and conversation with the oncologist, but thinking about would a low dose vaginal estrogen cream or topical estrogen be appropriate? We won't get into all the details, but like some patients it might be, particularly if they have like hormone negative disease or, you know, various other details. So just important to consider. Like there's maybe a question. Yeah. Continued indefinitely. Oh, yes, I think yeah, it can. It is totally fine. Continue it indefinitely. We'll talk about systemic hormone therapy in just a second, but topical, totally fine. Use it as you need it, unless you have breast cancer. Okay. Other things to think about that are common symptoms of menopause. So sleep disturbance is really common. And like I said before, a lot of these things kind of circle into one another. So hot flashes tend to be a big factor that cause sleep disturbance, but there's other, you know, mood issues that can cause sleep as well. So sleep disturbance, and then mental health effects. So estrogen really has this big effect on bone, brain, and heart. And so thinking about there's cognitive changes that can happen after menopause. People can have more issues with memory loss and concentration, and then also people can have there's an increase in the incidence of depression at menopausal transition. And when people do have these mood symptoms, that can in turn kind of like double down on the problems with cognitive function too. Other symptoms, breast tenderness, menstrual migraines can worsen, some joint pain, just a number of other things, but we won't get into those too much today. So question number 11, in clinic, after hearing about all of your great menopausal knowledge, Moira asks, can I start systemic hormone therapy? How confident are you in discussing hormone therapy for menopausal symptoms? I'll be really excited if like there are any. Oh, there are 5%. I wonder if that was Addie and Megan. I'm curious. Cool. Okay. Well, I'm really excited that like that there's really like most people feel like at least they can paint some broad strokes. That's pretty good. I also feel that way. And I think, you know, sometimes I feel like I can paint some broad strokes, but I definitely sometimes come out of the room feeling like, oh my God, call an adult. So let's just look at this. I am not going to go into detail and depth about the WHI study, which I'm sure all of you have sort of heard whispers about, but I think I put this picture up, which is from a Grand Rounds talk that was done at Brigham and Women's Hospital. But I think the lower, the lower section here, the CE and MPA, this is for the combined estrogen and progesterone therapy, which is the one that I think is most important to think about, just because we tend to not, more commonly we'll do estrogen and progesterone together. We don't tend to just do estrogen unless certain situations. But there is a higher risk for DVT, PE, stroke, and breast cancer. And I think if we think about, like, there are so many things on this chart and there's so many things in that study that kind of get like muddled, but if we just think about, like, we all know that estrogen from our contraception knowledge causes an increase, you know, we think about it with DVTs and PEs and all of these risks for clot and stroke, and breast cancer, of course, can be hormonally driven. So it's reasonable that those things are higher risk. But I think it's also just important to look at, like, the fact that it reduces all cancer types, reduces your risk for fracture, reduces your risk for diabetes. So these are not like across the board bad things to think about. So this is a little overview on hormone therapy. So really the best candidates to think about this in are really going to be simply your women between like 50 and 60. So they're under 60 years old. At 60, you kind of want to start to pump the brakes on it, but they have to be within 10 years of their menopause start too, which tends to be the 50 to 60 time range, or 45 to 55, whatever you want to think about. If they're in that window and they're having very bothersome symptoms, they have bone density that's of high concern, or that you think they have a high risk for fracture, and they don't have any of these contraindications, which, you know, tend to be like histories of the things that I just said could be like high risk for them, then you can think about prescribing this therapy. The way to prescribe it is that transdermal, like a patch, is better than oral. If women still have their uterus, then similar to like we were thinking about with PCOS, you do need to have a progesterone on board to like combat that growth of the endometrial lining. So you want to do that combo pill or the combo patch like I was talking about. Or you can do transdermal estrogen with like any kind of progestin if they have like something else that they take with progesterone. Trial it for 3 years or 5 years and then attempt to taper off. And if people during an extended discussion have like really strong desire to continue, you can think about it, but just trying to keep them at the lowest dose possible to manage their symptoms. And then this is just kind of thinking through some of the other things that I mentioned before. So hormone changes during menopause accelerate bone loss, increases cardiovascular risk factors, and puts people at higher risk for dementia, OA, skin changes, balance changes, all of these different things. And then really briefly, iatrogenic menopause. There are a number of things that will put people into menopause earlier than sort of naturally, that natural timeline that I talked about before. If people have had their ovaries removed for any reason, if they've had chemo or pelvic radiation that disrupted ovarian function, and then also people who have induced menopause symptoms. So breast cancer patients are like kind of the most common group of this population who are on hormone therapy, and they've kind of been pushed into menopause at a much earlier age. So just to summarize, average age of menopause is around 51 to 52. Menstrual changes and symptoms of menopause are driven by decreased estrogen. The most common symptoms are hot flashes and this vaginal atrophy or GMS, bone loss, sorry, that should say bone loss, cognitive decline, and sleep problems. There are methods for treatment. Really do consider hormone therapy if it could be beneficial to your patient. And breast cancer patients just have some unique risks to think about, but doesn't mean they are completely off the table for thinking about treatment for any of these symptoms. I think we may, like, I know we only have 10 more minutes, but we'll just push through to do a really brief overview of osteoporosis, just because I did mention all of the bone loss risk for patients who are going through menopause. And I think this is something that I certainly am trying to get better at recognizing and talking to patients about in clinic, especially during wellness visits. So osteoporosis, brief objectives, let's just look at some recommendations, discuss some steps in prevention, which I think is like the really important piece that we are going to be talking to people about over more years of their life, is really the prevention, and then just think about who we might want to consider treatment for. So all of us have probably heard the DEXA. We've seen this little distribution here. If you are under 1 to 2.5, you're in the osteopenia range. If you're under 2.5, really off the tail end here, then you are defined as having osteoporosis. Almost half of postmenopausal women do have low bone density, so it's really important to think through a lot of these things with those patients. The FRAX tool is something that we can use to estimate a 10-year, it's really, the tool was built to estimate 10-year risk of hip fracture or another major osteoporotic fracture in a patient who was not being treated and has some clinical risk factors. So the FRAC score and a DEXA scan are the things that we think about to start discussing osteoporosis or bone density screening. Osteoporosis, if you do diagnose it, either with a DEXA or a fragility fracture, you really want to think through, okay, do they have it because of their age, or is there something I'm missing? Is there a secondary cause going on? So a lot of labs we can do, I think basically CMP, CBC, FOS, TSH, and vitamin D, thinking through their calcium assessment. If there's risk for, if you're worried at all about malignancy, and SPEP, UPEP, and then testosterone for men. So when do we start to screen? So when should we even be broaching this topic with patients in clinic? The goal is really that we want to identify people who are at increased risk for fracture so that we can make an intervention. That's the point of the screening. So when you should think about it are all women over 65, postmenopausal women who are under 65 but have some risk factors that maybe are flagged in your mind as things that put them at higher risk of fracture. And then also men with those flags that you're talking about or thinking about. So anything that gives you clinical concerns for low bone loss, or low bone mass, I'm sorry. So if they've had a fracture in the past, if they have some height loss, if they are on steroids or androgen deprivation, those are all things to think about starting to screen. And the way that we screen, as I said before, is with a DEXA and with a FRAC, and you can do that with the FRAC score together. I think often the DEXAs come with FRAC scores in them sometimes too. Okay, so when we think about an osteoporotic fracture, it's actually not any fracture. There's a limited number of fractures that we want to really consider when we're thinking about osteoporosis. So that's hip fractures, vertebral compression fractures, and wrist fractures. I don't think that this is like a cut and dry list. I think there are other things that can be considered osteoporotic as well, but there's a lot of other things to think about the trauma that people sustain to get that fracture, and maybe why. Other things that it's, when I was talking about those groups that are not just women over 65, but other groups, what would we hear in their clinical history that could tip us off that they have high risk for fractures? That's people with low BMI, a parental hip fracture, steroid use, any fragility fractures they've had, smoking history, high alcohol use, or rheumatoid arthritis are things that we want to think about. So our final visit with Moira Rose today is that Mrs. Rose, now 67, living in Seattle, returns to you to discuss bone health. Which of the following is most important for prevention of poor bone health? Oh, yay, everyone got it right. Okay, cool. That circle is because I moved the slides down, I'm sorry. It should be around D, ignore that. You are all correct. So all those things are sort of like a piece of the puzzle of osteoporosis prevention, but really supplements for calcium are not recommended. There's a lot of guidance around trying to make sure people get it through daily intake. If for some reason they really just can't make that happen, or there's other things going on, you can think about a supplement, but the intake from food is really ideal. But once you hit that 1,000 to 1,200 milligrams, any more than that is really not useful. So if they are having a pretty healthy diet, and people are taking supplements, I think trying to just express that it's not really doing them any good. It could be just like an extra expense that maybe they don't need. Vitamin D, and I think something that is just worth thinking about in Seattle, especially is that if you have poor sunlight exposure sort of around the year, that regardless of, if you're 50 or 60 or 70, 1,000 units of vitamin D a day is a good thing to think about for prevention. Exercise, especially weight bearing, fall prevention, making sure that people's homes sort of are set up so that they are not at risk for tripping and falling. There's a great falls clinic at Harborview that I know a lot of people get a chance to spend time in. And then a healthy BMI, and sort of counter to a lot of things where we think about trying to reduce people's BMI, for this particular issue, having a low BMI, so 20 versus 25, puts you at higher risk. And then smoking cessation and alcohol, cutting back on alcohol, also super important. And then my final slide that I'll talk through is just treatment. And I feel like you could spend a whole academic half-day talk on osteoporosis treatment, and I will certainly not do it full justice today, but just to put it out there, it's patient and situation dependent. There are a lot of different recommendations, but in general, we can start to think about treating menopausal women with osteoporosis. So if you have a confirmed osteoporosis or fragility fracture history, or if you kind of fit this high risk picture, so you have osteopenia and you have a high FRAX score or a high fracture risk, then you can start to think about treating these patients. And the FRAX score for any fracture over 20%, and then 10-year risk of hip fracture over 3%. Treatment options, the big ones that are like the initial therapy to think through are bisphosphonates. So alendronate and risedronate are some of the common ones. And then there are, if there are contraindications to bisphosphonates, or if there are case-specific situations, which are a number of them, I won't get into them today for lack of time, but anabolic agents, and then denosumab, raloxifene can all be sort of other options beyond the bisphosphonates to be aware of. So a summary from osteoporosis: it's diagnosed at a T-score of less than 2.5 or equal to 2.5. Osteoporosis diagnosis needs a workup for an underlying cause, so just do consider if there's something else perhaps going on. Start your screening for all women at 65 and up, and then all postmenopausal women or men, or postmenopausal women under 65 and men who have a higher risk for fractures. And the prevention measures are super important, both before anyone even has a low bone mineral density, but also once they do develop low bone mineral density, those things are all still important to continue thinking about, like they don't go by the wayside once someone has osteopenia. I think that is all. So thank you so much. I know that was a long session.
Workup needed for osteopenia?
Great question. I don't think so.
It's like really early on or something.
Yeah, that's a great point. My gut would be like if they're young, if they are sort of like, certainly if they're premenopausal, if they're, you know, under 60, I would think about it, but I don't know that I have it in my practice.
So a quick question about vitamin D and muscle health, and any evidence you encountered about that in the chat.
I feel like I've heard that goes back, whether it prevents falls, whether it, like, you know, can help. I'm still like not really sure.
Yeah, I think we are not entirely sure. I think there's a lot of back and forth evidence and guidelines that go on about that. So unfortunately, I cannot say.
I think there's a recent journal watch. I saw something, I didn't read the whole thing, but about maybe vitamin D isn't for everyone. So I think it's still evolving.
Yeah. If you do a rotation in geriatrics inpatient, you will certainly feel like everyone gets vitamin D. And I think in, you know, a lot of our like really elderly patients, it does make a lot of sense if you're just thinking through their risks. But yeah, I can't speak for sure about when and how.
Yeah, I think I recently saw something, also didn't do a huge background search on it, but that if they're not otherwise like deficient or haven't had a fracture, someone with sort of like a normal vitamin D or no reason to be deficient there's no added benefit to the vitamin D that they get. That may have been just in terms of fracture risk. So as far as some of the reasons that the geriatricians prescribe it, that may not apply to what I'm suggesting.
Okay.
Well, thank you, Women's Health Team and Pathway. This was awesome. Thank you for letting us spend the day with Moira. I loved it. We'll upload the slides for people's reference because there were a lot of great like algorithms and things like that that people might want to refer to. So just a quick plug for our digital curriculum. If anyone's having trouble finding something or needs a reminder, please let me know. But Courtney and I try to include the link in our academic half day reminder emails. So hopefully you guys can find it, but let me know if that's not the case.
Awesome. Thank you so much for all your great questions, and thanks for everyone for hanging with us for 3 hours of talking.